Hi, everyone. Welcome to this special CBME seminar, the third edition of the CBME seminar. I'm Owen Schaefer with the Center for Biomedical Ethics. I'll be chairing today's session. Thanks for those of you for joining us from around the globe and the colleagues here at the Center for Biomedical Ethics who are in here in person as well. Today's speaker is Professor Angela Ballantyne, a longtime friend of the Center for Biomedical Ethics. She'll be talking, as you'll see, about balancing utility and equity in COVID resource allocation with an emphasis on the ICU care, but also looking at some other resource allocations. So to briefly introduce Angela, she is a professor with the Department of Primary Healthcare and General Practice at the University of Otago in New Zealand. Her research interests include exploitation, research ethics, vulnerability, ethics of pregnancy, reproductive technologies, secondary use of clinical data, among other topics. And she's, in the past, among other things, held visiting appointments with us, and she's been working with us and continues to work with us on a number of fascinating projects in biomedical ethics.
For the talk today, I'm going to focus a bit on data from New Zealand. Sometimes I think New Zealand's such a small, tiny country at the bottom of the world, you know, who wants to hear about New Zealand? But I'm hoping that's going to be of interest to a Singaporean audience, in part because both Singapore and New Zealand were recognised as doing quite well in terms of managing COVID. And I think during 2020 and 2021, there was quite a lot of interest from Singapore and in New Zealand in what the other country was doing, kind of interest in different management strategies. So hoping that for a Singapore audience, some discussion around how New Zealand dealt with equity concerns in relation to resource allocation will be useful. I'm going to talk a bit about racism and systemic health disparities. I did sort of start looking at some data on Singapore, but to be honest, I'm not really an expert in that space. We've got lots of time for questions, and I know there's lots of clinicians online. So I'm really hoping that you will be able to bring that Singapore perspective in terms of the discussion towards the end. I'm going to draw a little bit on data from the US, in part because there's just a lot more data and analysis and modeling from that area. Okay. So I want to start by just kind of painting a timeline in terms of resource allocation. So we can start really broadly looking at social determinants of health. That would be education, housing, access to clean and non-polluted environment. All of these social resources impact on people's underlying health status. Then we can look at allocation of preventative resources. So that might be, for example, PPE, access to masks, access to vaccines. Then we can look at patients who actually get sick from COVID and might need treatment. So in-hospital treatment, for example, access to antivirals. And then a smaller number of patients will be critically sick, really severely sick, and might need access to ICU. Sometimes, one of the narratives that we read and hear about is that at the pointy end of this wedge in relation to kind of critical care and ICU is not the time to be worrying about justice and equity. We can worry about that in relation to the social determinants of health. Now, I want to challenge that narrative today and actually argue that equity and justice is something we should be considering, across this health pathway. So the three values I'm going to talk about today broadly are justice and or equity, public benefit, and individuals' best interests. And I think questions around resource allocation draw on these three values, but how they intersect at different time points across this continuum will be different. So, for example, questions around individuals' best interests, I don't think are that pertinent in relation to the social determinants of health or preventative health resources, because for almost everybody, access to vaccines, access to PPE, access to good education is going to be beneficial. However, when we get to treatment, and particularly questions around whether that's actually in the individual's best interests become more relevant. And so how we balance kind of these three considerations across resource allocation issues is going to be the focus of the talk. Unpacking things a little more depth, this is a model of some of the principles that we see in the ethics literature around rationing resources under crisis standards, so crisis care standards. For most of the literature, there's kind of a background assumption that all the resources will be in the individual's net best interests. I'm going to challenge that a little bit when we come to ICU, but I think in the literature, that's a general background assumption that everybody wants the resources. It's just a question of who we choose to give them to. Of these kind of 6 principles, I think 4 are primarily motivated by concern with justice, and 2 are motivated by concern around public benefit, efficiency, maximising the benefit we get from our resources. So quickly running through these, One principle is non-discrimination. There's general consensus that resource allocation tools shouldn't discriminate on kind of known grounds of privilege. So, for example, they shouldn't be given out on the grounds of sexual orientation, religious status, gender, for example. There's quite a dominant critique from the disability community arguing that some of the triage standards did amount to discrimination on the grounds of disability, and there were legal challenges, for example, in the US of some states' triage policies on those grounds. The next concern, justice concern, is equity. That's really about health disparities. So I'll go into more detail around what equity is later, but briefly, I quite like the WHO definition, which is that equity is the absence of unfair, avoidable, or remedial differences between groups. So an equity concern would say, not everybody comes into the pandemic with an equal amount of privilege or health status, and we should use some of our resources to actively try and address those health disparities. Life stages refers to the idea that we should be kind of fairly entitled to a relatively equal amount of life. So if we were comparing two patients with similar health status, one who was 25 and one who was 75, the 75-year-old has already lived a fair proportion of their kind of natural or expected lifespan. So we should give priority to the younger patient. The idea of reciprocity was discussed mainly in relation to healthcare workers, and acknowledging that actually many healthcare workers have taken on a really undue burden of risk during the pandemic, and often that will be the reason that they have contracted COVID. So because they have done above and beyond what would be expected for society, society has a reciprocal obligation on the grounds of fairness to give them priority access to resources. That's really kind of a retrospective perspective. It's something that's an acknowledgement of what people have done in the past as a contribution to society. That kind of relates to the idea of instrumental value, but instrumental value is forward-looking. So there you might say, well, there's certain critical workers who we really need as the backbone of our pandemic response. So if, for example, all our ICU doctors get sick and aren't at work or die, it kind of doesn't matter who we allocate to ICU beds because there's no staff. So instrumental value really says there's some key groups who we need to protect because they serve all of us moving forward. And so we might give them priority access to resources like vaccines, for example. And that's a concern motivated by benefit, right? What's the public benefit offered by certain groups, certain workforces? And then we come to the one that was most dominant, which is saving the most lives. So the really kind of most influential ethical value or idea in relation to resource allocation across the board was the idea of saving the most lives. That's sometimes referred to as utility or efficiency, sometimes broken saving the most life years. So not just the most lives, for people to live for a year, but saving the most life years overall. It's an aggregate measure. It looks at the benefit for the population as a whole. So if we look at kind of a couple of examples of people arguing in favour of this idea that saving the most lives was the most important value. We start with Don Wilkinson, a philosopher and clinician from Oxford, who argues that the ethical balance during a crisis, for a pandemic, for example, must shift to emphasising benefit. This will mean prioritising intensive care for those patients who have the highest chance of surviving. And this little image here is taken from Dom's work, and you can see that what he is suggesting is that as we move from kind of normal ICU context into an impending pandemic and then triage and crisis, ideas about fairness and justice become less important, and ideas around benefit and saving the most lives become more dominant. The next quote is from a very influential paper by Zeke Emanuel and colleagues. This paper's been cited like over 1,500 times, so it was really influential in terms of the kind of global debate around resource allocation. They argued that priority for limited resources should aim both at saving the most lives and at maximising improvement in individuals' post-treatment length of life. So saving lives, but also saving life years. Saving more lives and more years of life is a consensus value across expert reports. Now, I would agree with that statement early on in terms of sort of early 2020, and I'll kind of come back to this a little bit later. And that paper was published in March 2020. I think over the last 2 years, we have seen a shift away from that and a refocusing on the importance of equity. But I think that was there's a fair statement of the kind of consensus position in early 2020, in part because at that point, there was really significant concern about health systems being very overwhelmed. And that has happened to some degree, in some countries and some states, but certainly in New Zealand, the health system was not as overwhelmed as we feared it might be. And I think the same could be said for Singapore. And then George Markman is a German philosopher. As a basic rule, we try to act in such a way that the largest number of people survive, because that is in the public interest. Now, I'm going to argue today that actually the public interest has two components, and that public health ethics has two primary values. One is benefit and the other is justice. And I don't think in a pandemic or a crisis that's sufficient reason to set aside concerns of justice and equity. To look in a little more detail, this is a table from that Zeke Emanuel paper that was really influential. And here they work through a number of ethical values. So they say maximising benefits is the most important. That means saving the most life years and the most lives. Treating people equally. They look at a couple of principles related to that. They say that first come, first serve shouldn't be used, in part because this can give priority to people that have better access to healthcare. So that can be unfair because often privilege is associated with having better access to healthcare, spatially, for example. Random selection can be used, but only when, as a tiebreaker really, when comparing two patients with similar prognosis. And they do talk about reciprocity, for example, that can be relevant. And also giving value to healthcare workers because they're most likely to offer that kind of instrumental value to the community as a whole. Giving priority to the worst off is kind of as close as they get to looking at equity or justice considerations, I think. They say you could prioritise the sickest, but only when it aligns with maximising benefits. And you could prioritise the youngest people. That's that idea around life stages, when it aligns with maximising benefits. Now, I suppose this is where I disagree. So I think that it is reasonable to prioritise patients who are sicker if that sickness and if that kind of baseline health status comes about as a result of systemic injustice in society. Under those circumstances, I don't think the fact that a patient has a better prognosis because they've already been privileged in a series of ways that are unfair as a result of kind of systemic bias in our social system, I don't think that entitles them to additional resources during a time of crisis. So equity, as a individual value really doesn't play a part of this account at all. So essentially we come up with kind of a debate in terms of utility and equity. We can save more lives, but I think the lives that are likely to be easiest to save are the lives of privilege. And that's because when you look at allocating resources, particularly like ICU, those patients who are going to need ICU for a shorter amount of time and are more likely to survive are those with better underlying health status. There are 4 health features or health conditions that are quite predictive of severity of COVID and death for COVID, and those are diabetes, hypertension, heart failure, and obesity. And all of those are understood to be conditions, health conditions associated with deprivation, right? Those are health conditions that result primarily from the lived environment that people have and correlate very closely with socioeconomic status, for example. So if we just maximise life saves, we're likely to maximise the lives of the easy people who it is to save, and those are people of privilege. Or equity might say that actually we should use some of our resources to look at who gets saved. So we should look not just at aggregate lives saved, but actually how those resources are distributed amongst communities. And that there's a value in terms of justice, diversity, and inclusion, and really trying to ensure that groups who have been systemically disadvantaged actually get access to some resources. So we save a more diverse group of patients. Now, the kicker here is at the pointy end, that is going to mean, and the point where it's ethically interesting, that is going to mean saving fewer lives. So we could, for example, argue about saving 200 lives, but they might be lives of privilege, or we save 150 lives, but we might have more diverse patients survive in that model. So that's sort of the ethical challenge. Now, so this brings us to the issue of kind of race and ethnicity, socioeconomic status, and how that played out during the COVID pandemic. And I think over the last 2 or 3 years, there's just been a huge amount of evidence that not everyone was at equal risk of COVID, and that actually race, for example, played a kind of significant role in that. So this first image here, COVID's devastating impact on African Americans, looks, the little blue number there is the percentage of African Americans in each state. So in Louisiana, for example, that's 32%. And then the red line is the number of deaths, so 70% of COVID deaths. So you can see throughout here that people who are African American or Black in the US are dying at a really disproportionate rate relative to their representation in the population. The image over on the other side is from the UK. Now, the little blue line is the prediction of hospital deaths adjusted for age and location. So what they did here is took each of these ethnic groups and said, actually, one thing that's going on is that sometimes different ethnic minority groups are more likely to live in different geographical centres, so they're more likely to live in urban areas with high density. That puts them at greater risk of COVID. But on average, they're younger than white populations, for example. That puts them at lower risk. So if you try and even that out, so you adjust for location and age, you then get a sort of a slightly more neutral or representative predicted risk of death based on ethnicity. And you can see that for almost all of these, except for Black Caribbean, you would expect the death rates to be lower than a British white population. But the yellow line is actual hospital deaths. So, and again, in all these cases, the outcome for these groups was worse than would be predicted. And that's kind of at an academic level, but on a kind of media level, these kind of disparities received a huge amount of media attention. And I think for the, maybe not the first time, but were really emphasized as part of the public discourse. And I think, in some places and for some members of the public, this might be the first time they really grappled with racial health disparities. And, a lot of shift, for example, in terms of language. There's lots of discussion now in New Zealand about systemic racism and health. We might have talked about bias before, but really introducing language that for some is more confronting. So what is structural racism? I would define that as laws, policies, and social norms, which can be unconscious or conscious, that disadvantage racialized and ethnic groups via barriers to healthcare, disempowerment, and denial of resources that results in inequitable and avoidable health disparities. This is a special issue of Bioethics, the journal Bioethics, that looks at racism in healthcare and bioethics, that just came out a few months ago, that I had the pleasure to guest edit. It's important to note that race is a social construct. It's not a biological construct. Race refers to a social process which categorizes people based on commonalities of their physical features. There's no biological way of kind of defining different racial groups. It's a social process. And it's similar to ethnicity, but ethnicity is defined as, again, a social process, but groups that are grouped together based on common cultural or national heritage. So one sort of cultural and one refers to physical features. And there's a kind of, just a huge amount of literature around various forms of bias in medicine. I've got some examples here around weight and obesity, different, bias relating to pain for women, evidence of bias relating to race and ethnicity. So I'm not going to go through all of that in detail. And this is kind of, only a tiny snapshot of this. But just to say that I think there's growing recognition in both the academic literature and in the kind of popular media discourse that our health system is biased in many ways, a lot of which operates at the level of kind of unconscious bias and can be, quite difficult to remove. What all this means is that patients, because of the systemic bias in the health system, don't come into a crisis with equal health status, right? They come in with years and years of either privilege or disadvantage based on a whole range of kind of intersecting features. So weight, height, attractiveness, gender, sexual orientation, race, and so forth. So this brings us to a focus on equity. And I think, as I said, like across towards the end of 2020, really in 2021, as a result of some of these public debates around, Black Lives Matter and acknowledgements of that in the US, equity started to take more of a central focus. So equity is the absence of avoidable or unfair or remedial differences between groups of people, whether those groups are defined socially, economically, demographically, or geographically, or another form of stratification. This is a really famous cartoon. I'm sure many of you have seen it before. Illustrates the difference between equality and equity. Equality is giving everybody the same amount of resource, but because people have different needs, that doesn't mean they're going to get the same outcome. Equity is about giving people differential resources in order that they can achieve the same outcome. Now, what that might mean in relation to ICU, for example, is if you have a black patient come into ICU compared to a white patient, and that black patient comes in with higher rates of comorbidity, multimorbidity, obesity, worse underlying health status, they might need longer in ICU to achieve the same health outcome as someone who's white. Right? So that's how the idea of equity can influence resource allocation issues. Policies can do one of three things. They can exacerbate health inequities. And that was really the concern, for example, about ICU triage, is that it would continue to perpetuate and make worse the health disparities between different ethnic and racial groups. They can be neutral, or they can try and reduce and close those disparities. So if we look at some of the international literature, this is the WHO's COVID-19 Strategic Preparedness Plan, really strong focus on equity. So they say that WHO's commitment to gender equality, health equity, and human rights need to be mainstreamed in operations right from the outset across your pandemic response. WHO recommends that all countries conduct substantive gender equity and inclusion analyses, and conclude by saying the evidence is clear. Solidarity, equity, and global leadership are the only routes out of this pandemic. And the reason they're saying that is because, I would argue that focus on equity and justice is kind of an inherently right anyway, but it also serves an instrumental purpose. So if you look at all those media stories I showed you about health disparities, that really creates, it really challenges social cohesion. And one of the reasons both New Zealand and Singapore were really successful in relation to the pandemic was a high degree of social cohesion. When you're trying to get people to follow public health measures, it really matters that they trust the government, they trust each other, they think the system's fair, and they're prepared to kind of cooperate with those measures. So that's why equity, is valuable, not just in and of itself. It's not just the right thing to do. It actually has kind of instrumental value as well. This is New Zealand's report that kind of came out in 2020. This was our kind of on the ground, thinking fast report. So NEAC is our National Ethics Advisory Committee. I was involved with drafting sections of this and, advising on the content. So I'm going to say it really emphasizes equity, but I do feel like I have to say that, obviously I think that's a good thing because I was somewhat involved here. But here you can see that, equity was in the title, ethics and equity. That was a really strong framework in New Zealand. We argued that equity needs to be at the forefront of all decision-making. We need to take steps to promote equity in allocation across the board, and we need to avoid exacerbating existing inequities. This is our more considered piece of work. So this has just come out now in New Zealand. It's under consultation at the moment, Ethical Guidance for a Pandemic, in part because I think a lot of countries realised that they had pandemic plans, but they weren't as useful as we hoped they might have been when we actually found ourselves in the pandemic, and the kinds of challenges we had weren't necessarily ones we anticipated. So this is out for consultation now in New Zealand. It has 6 primary principles, a number of which are Māori principles like kotahitanga, manaakitanga. But here you'll see again, equity is really, a substantive focus. So to put all of that into action, what would it look like to adopt an equity-informed approach to resource allocation? Really what we're talking about there is sort of often starting with an allocation process that looks at maximising benefits and then tweaking that or dialing it or shifting it somewhat in order to try and move more resources to high needs groups who are marginalised and suffering poor health as a result of injustice. So a couple of things we did in New Zealand in relation to vaccine distribution, and then I'll move on to ICU. We did 2 things. One is we allocated specific resources to Māori health providers. So Māori is the Indigenous population in New Zealand. About 17% of the population, but at significantly higher risk for COVID. So for example, had 2.5 times the rate of a kind of European New Zealander risk of having severe COVID and needing to be hospitalised. We also allocated decision-making power, and this is really important. It's not just about resources, it's about autonomy and self-determination in terms of how you control those resources. So for example, New Zealand, when we rolled out our vaccine, we did it by age brackets, age being the primary indicator of risk for COVID. So started out without kind of over 80s and went down slowly. And New Zealand didn't have a lot of vaccine, so it took a long time for that to trickle down to, people my age and their 40s. And, we were kind of really waiting to get our hands on vaccines. However, Māori were given the option, some Māori vaccinators were given the option of actually vaccinating entire whānau or families at a time. And in part, that's because they thought it was going to be more difficult to bring each person in that family back in to get vaccinated, as the age bands went down. So that was an example of allowing those providers to distribute the vaccine in a way they thought was more culturally appropriate for those groups. We also collected ethnicity data for vaccinations and actually, really invested in how we collected ethnicity data. And in part, for example, that was we had been collecting some data that grouped Māori together as a whole. But, Māori health providers said to us, look, that's not that much use to us because we're not all the same. And what we want is data by iwi. So, for example, tribal group. So in part, in terms of trying to address that need, we invested in how our kind of data collection system. But one thing we didn't do. So I was on the Immunisation Implementation Advisory Group, which was a group at the Ministry of Health who advised the government directly on how to roll out the vaccine plan. And we had suggested and endorsed this kind of age bracket rollout. But our advice had been that we should actually have an ethnicity adjustment to that. So, for example, we knew based on the data that Māori age 44 and people of Pacific ethnicity age 40 had a similar risk factor to European or white people age 65. So we said we should have a dual rollout. When 65-year-olds who were white were getting vaccinated, actually Pacific and Māori people who were 45 should be vaccinated. Now, the government didn't accept that. That was really controversial. We had really significant members of this advisory group resign as a result. I think they didn't accept it due to kind of political reasons. But interestingly, when it came to the flu vaccines this year, so a year later, they did implement an explicit ethnicity differential for Māori and Pacifica with the flu vaccine. So in New Zealand, if you're over 65, you get a free flu vaccine unless you're Māori or Pacific, and then you only need to be over 55 to get that flu jab. So that's, again, kind of interesting how that debate shifted over time. New Zealand vaccination rates overall were really high, only really the 5 to 11s that we didn't have really high numbers of vaccination rates. So this is, overall very high rates of vaccination. This is looking at comparisons for Māori and Pacific relative to the European or Pākehā population in New Zealand. So this is a rate ratio. If it was completely even at 1, it would mean there was no disparity between the vaccination rates for Māori and Pacific people and for white or non-Māori and Pacific New Zealanders. If the little coloured graph is coming down, that means that there's a disparity that favours white people. So Māori and Pacific people are getting vaccinated at a slightly lower rate. And if it goes up, it means they're getting vaccinated at a higher rate to white people. You can see there's a few tiny blue parts there that go up. So those is really as a result of an amazing effort by our vaccinators in the Pacific community. There's a bit of a disparity there, but personally, I think this is actually pretty impressive in terms of the vaccine rollout and the risks that we thought there was going to be in terms of that disparity. So actually, I think that's a reasonable success story. So let's turn now to look at equity in relation to critical care. So one of the things, the point I wanted to make is that what you can do in terms of achieving equity for a preventative resource like vaccines or PPE is much less complicated than if you're looking at a resource like ICU. And that's in part because ICU is a really burdensome treatment. It comes with a whole lot of risks, whereas something like a vaccine is very high benefit, low risk. So I do think you really need to pay attention to the nature of the resource when you're thinking about how to implement an equity response. So here are a few different strategies that have been put on the table in terms of how you could adjust or kind of shift the dial on an ICU triage document to achieve a more equitable outcome. You could introduce a correction factor into patients' triage scores. This is generally thought to, is referred to, well, one that is suggested is the area deprivation index. It's a statistical tool they use in the US. It measures deprivation in kind of geographical pockets, and is quite a close proxy for socioeconomic disadvantage and also racial disadvantage in the US. So one suggestion is that you can use that on top of your existing SOFA score to adjust it to give kind of priority access to people who are coming in from an area of deprivation. You can give greater priority to individuals in high-risk occupations. So there was a reciprocity focus on healthcare workers. Some have argued that actually we should expand that much more generally. So to include bus drivers, people, cleaners, people running, cleaning city streets, people removing trash, people working in supermarkets. Often, though, and for example, in the US, people working in those occupations have higher rates of, African American or Hispanic ethnicity, and serving those in those roles is an essential social service and puts them at risk of getting COVID. So one way we could try and acknowledge that is to include all of those groups in our reciprocity priority system, not just health providers. You could give longer ICU time trials for disadvantaged populations. Research suggests, for example, that to get the same outcome from ICU, African American patients need access to ICU for longer. You could adjust or drop the creatinine measure in SOFA. So the creatinine measure really measures kidney function. It's controversial because it closely, again, correlates with health conditions that are associated with kind of poor health status as a result of lived conditions, so of kind of social bias or deprivation. The difficulty with that is that if you start mucking with internal components of the SOFA score, you risk invalidating the SOFA score as a whole. So, but there's debate about that. Rejecting the use of longer-term life expectancy. So when trying to do prognosis for patients going into ICU, not looking, for example, at 5-year expected survival, but limiting that to 1 year, that can limit some of the impact on disparities in the model. And obviously, like avoiding discrimination, so not using quality of life measures, not categorically excluding certain disabilities or sexual orientation, for example. So these are kind of all on the table as possible ways of implementing an equity approach to ICU triage. Sort of tricky to know how they'll play out. There's some debate about this. This is a paper, or a letter to the editor actually, by Ross Driscoll and colleagues. And can you actually see the top bit? Is my bit in the way there? Maybe if I move up here. Do you know how to make that bit go away?
Try clicking.
There?
No. Oh,
no. All right. Okay. Sorry about that. I'll have to tell you what the top says. Basically, the 4 different lines are different models of trying to adjust SOFA. So the first one is your baseline. It's SOFA as well as the underlying conditions questionnaire. And that is the one that kind of tries to estimate prognosis and survival up to 5 years, for example. The second one uses the ADI, so the area deprivation index, and adjusts the score based on that. The next one uses the underlying conditions questions, but limits prognosis to only 1 year. So not longer term prognosis, short-term survival prognosis. And the last column uses the area deprivation index and limits prognosis and mortality to only 1 year. And what you can see here is that when they use the data, I mean, this is a reasonably small study. It's 4 hospitals in Atlanta, 3,000 patients. None of these different models really had any impact on access to ICU for white and Black patients. So I suppose, there are other studies that give you slightly different outcomes. So this isn't the be all and end all, but really just to say it's important for ethicists when we're talking about models that are that kind of need to be used in practice and the values that should inform those models, to ensure that we're always evaluating how those models actually play out in practice. So it's one thing to sort of say we should adjust a SOFA score to take account of all these equity considerations. It really matters how that's actually going to play out in practice and whether it's going to work. If we look at access to hospitals and ICUs in New Zealand, there wasn't a huge disparity between Māori and Pacific and white patients in the end. This is a little bit harder to follow, but essentially, so 104, this is kind of up-to-date data, 104 Māori patients needed ICU care for COVID out of 2,500 who are hospitalised, so that's about 4%. So about 4% of Pacific people who were hospitalized also ended up in ICU. For the Asian population, that was 3%, and for European or other, it was 3%. So what this suggests that we weren't seeing a situation where a whole lot of sick patients came into hospital, but then the ICU triage tool was really unfair in terms of blocking access to Māori or Pacific patients in terms of getting into ICU. That's in part because New Zealand ICUs just weren't as overwhelmed in the end as we expected they might be. All right, so now let's complicate things a bit further. So one of the things that's really tricky about ICU as a resource is that it's really burdensome. So, there's a lot of this sort of assumption that ICU will be beneficial, and there was a lot of debate about who was going to get this, like a lollipop, who was going to get this really valuable resource. ICU, of course, is potentially life-saving, but it's also burdensome, and it can prolong death, and it can exacerbate suffering at the end of life. Clinicians, and this is, clinicians we spoke to in Wellington and in New Zealand, said actually, if you use an equity model that pushes a whole lot of sicker, frailer patients into ICU, you might actually just be causing them harm rather than offering them some kind of benefit. And, data emerging through the pandemic showed that 50 to 88% of ventilated patients for COVID died anyway. So it wasn't this, I think in the public discourse and maybe amongst, ethicists as well, particularly who didn't have a clinical background, there was this assumption that, if you got into ICU, it saved your life. So whose lives are we going to save? But actually, most patients still died, and they died in an ICU that wasn't a very nice death. So again, like the kind of the reality of the situation is really important. But you can imagine for social groups that have experienced decades of a biased health system and have significant distrust of the health system, when clinicians turn around and say, when you get lower priority access to ICU, not because we're maximizing overall aggregate utility, but because it's not in your best interests, you can imagine the kind of response. And I was in meetings, that played out like this. The response was not very good, and it wasn't good because representatives, Māori health doctors and advocates had so little trust of the system as a result, of kind of decades of injustice. So navigating that difference between we're trying to maximize a resource and you don't qualify versus actually given your health status, ICU isn't going to be in your best interest. Navigating that distinction requires a really strong therapeutic relationship and a lot of public trust. And kind of brings us back to why focusing on equity throughout the whole care pathway is really important, in part to build that trust. Okay, so even so, and this kind of draws on to papers I co-authored in 2020. So even if we say, okay, in some cases, putting frailer patients into ICU isn't going to be in their best interest, that's not necessarily the end of the equity story. There's lots of other things we can consider in terms of an equity response to really severely sick patients. And part of this comes down to Nancy Fraser's distinction around kind of empowerment and voice and epistemic justice, as well as resources. So she argues that recognition seeks to secure equal respect for individuals for whom it's been denied. So certain patient groups have been disempowered and their voice has been ignored within the health system. And redistribution seeks to correct unfair disparities and advantages or resources of certain kinds. So part of what this is saying is if you want to build trust in terms of, and collective buy-in behind your ICU triage, that kind of idea, nothing about us without us. You have to ensure that you've consulted widely and that you've got people who come from groups who have been historically disadvantaged as part of that process, and actually they can feed into building those triage tools. Funding for palliative care is really important. So if you're going to shift patients away from ICU because you think it's not in their best interest, we shouldn't be using all of our COVID resources simply on ICU. Palliative care and a good death and access to kind of care at the end of life is important as well. Resources for advanced care planning, communication, and decision support are really important. So, for example, actually, I'll do the next bit. So, and allocating scarce PPE for visitors and support people. It might be that people with disabilities, for example, or for sort of certain cultural reasons, it's more important for some groups to have visitors in ICU. Now, often that was very limited in ICU, and PPE was allocated only for clinicians, and that comes from that whole model of maximising the number of lives saved. If you are taking an equity focus, you could use some of those resources to ensure, for example, patients with a disability, patients who needed full-time kind of personal carers were available. There's other mechanisms in terms of communication support. So, for example, one element of the SOFA score that is contentious is the Glasgow Coma Scale, which looks at patients' ability to communicate and gives people a worse score if they are inarticulate or say kind of incomprehensible things. This means that patients who are deaf, hearing impaired, have a speech impairment, score worse on those kind of scoring factors. Now, one of the solutions here is actually relatively easy. It's ensuring that you have kind of Wi-Fi available and devices available so that people can, download and have access to language communication apps that can kind of compensate for that impairment. So investing in all these kind of resources that go around hospital care or around ICU is a way of addressing equity in this space as well. So in summary, public health has two goals, public benefit and justice. And I think justice needs to be considered, throughout our discussions around pandemic planning and at all points in our resource allocation. I don't think it's reasonable to say we just need to focus on justice and equity in relation to the social determinants of health. We can think about equity even in relation to allocating critical care resources like ICU. How best to achieve equity is tricky, and that depends on the nature of the resource. And it's really important, as I said, to involve affected groups in that discussion and that planning. ICU is actually burdensome care and may not be in a patient's best interests, but getting patient trust to kind of accept that is tricky in the context of really significant health disparities. So patient trust in the health system overall, and including clinician judgment and fairness, is undermined by systemic bias, which is why addressing sources of bias in the health system is really important, not just in an end in of itself, but in terms of demonstrating trustworthiness to the public at large. That's probably enough from me. And I look forward to hearing about the Singaporean experience, the extent to which Singapore focused on equity considerations, how that played out, and any questions. Thank you.
Maybe I'll start with a question for Angela. So you framed this talk in relation to, among others, Zeke Manuel and his colleagues' framework, which, as you say, has been very influential. I guess I'm wondering how much you're really deviating in the end from the general contours of that framework, aside from there's some things they say about, say, life expectancy. Because one of the key things about the framework, they don't say sort of ignore equity. Instead, it is the idea of benefits first. And what that means is you start with sort of a benefit analysis, maybe through SOFA or something else, and then you modify that potentially based on equity, right? And then one point they say, well, you only modify it if it aligns with general outcomes, right? So you don't have this strict trade-off. But then that seemed to align with one of the examples you had with vaccines, because it said, well, maybe you should put in, I think it was an ethnicity or ethnicity weighting. So that was partly because this ethnic group has worse outcomes, right? So it serves the equity goal, but it also serves the benefit goal. Even that one didn't get accepted, but it still would have been sort of this double duty one. They didn't kind of have an example of the real tough one where it's like you actually they would do better off in that group, but and you would you would still prioritize them. So I was wondering whether is it really deviating that much, or is it just about emphasis and emphasizing more than they do the value of equity? All
right, so a few things in there. So I think it does deviate from their account. They do have some justice considerations in terms of reciprocity, for example, or serving the worst off, but they don't specifically address equity. And I think what's distinctive about equity is disparities that result from injustice in the background circumstances, right? So it's not just that this group is kind of accidentally or surprisingly sicker. It's saying that the health status that we have comes from this historical injustice, and therefore there's a specific reason to allocate resources to try and address that. And I think it's really important to recognise that. So the fact they don't use equity at all, even though they think about some other justice considerations, I think first of all is problematic. Yes, there are scenarios where equity and maximising benefits will align, and that's a good example, right? Where giving the vaccines to Māori at a younger age, it just followed the science, right? That was kind of the risk profile. I think there are other areas where they might come into clash, and I suppose those are the more interesting ones. So, for example, giving certain patients access to ICU for longer would be one example there. And I think there was controversy in New Zealand in terms of the whānau approach to vaccine distribution for Māori and Pacific groups, because for other groups, white groups, we had to go in, get our vaccine, you have to take the whole family in, every time there's a new age bracket. So it would have been more convenient for everybody if we could all have just taken the whole family in as soon as one person in that family reached the top age bracket. And so, yeah, certainly that, that had implications for other groups. Yeah.
Thanks very much. There's some hands being raised online. Maybe we'll start with one of the hands that's raised. Morali, you have defined equity. Are you begging the question in favor of a strong version of egalitarianism and it's against a more libertarian, sufficientarian, or prioritarian account? Is this just low-hanging fruit that people can endorse regardless which version of justice you accept? Or is this a matter of plugging in the right account of distributive justice, whatever that account is?
Yeah, so I guess I would say I think you can support that account of equity regardless of specific views about your kind of view on distributive justice, in part because it stems from an acknowledgement that the system is biased. So a lot of the kind of philosophical work in relation to justice can assume that everyone's starting at an even playing field, and that isn't necessarily, the actual reality of lived people's lives. So I think across the board in those different accounts, you get a lot of acceptance for the fact that if the different kind of health outcome for different groups is as a result of a prior injustice, that requires some rectification. I think endorsing that sort of idea can be broadly accepted.
Okay, thanks very much. Next, maybe Julian Savulescu. Will you unmute yourself?
Yeah, hi, Angela. Thank you for that very interesting talk. I just wanted to get a little bit clearer just what you meant by justice. So there's a long-standing debate around egalitarianism versus utilitarianism, that on the one hand, people say we should maximize utility or benefit, and other people say we should treat people according to need, equal treatment for equal need. That's a very familiar version of egalitarianism. So the Black patient that needs ICU for 2 weeks should have an equal chance of getting that compared to a white patient who needs it for 1 week. So that's really just a sort of long-standing debate. But you also raised these issues around past structural injustice. And I wondered whether you felt that this was a criterion that needed to be considered under a justice approach separate to simply straight egalitarianism or equal treatment for equal need. So if you have a Black patient who needs the ventilator for 2 weeks and a white patient who needs the ventilator for 2 weeks, the Black patient should have priority because of past social injustice. So do you take that sort of more retrospective version of egalitarianism to be what's necessary for justice? And if you do, it would seem that you kind of subscribe to a view of social responsibility for illness, that society has a responsibility for the illness that's caused in people. But do you also extend that to personal responsibility? So do you think that we should also take into account the contribution that people make themselves to the probability of them becoming ill or severely ill? So if we accept social responsibility, should we accept personal responsibility?
Great question. Yes, I think I do endorse a version, say, of egalitarianism that is retrospective and takes account of historical injustice. So for me, there's a difference between a Black patient needing access to ICU for 2 weeks as a result of some genetic condition they were born with, that's just bad luck, moral bad luck, as opposed to a result of structural biases in the social system that are remediable. So I think that's really the key for the WHO definition, right? It's some disparities arise and they're not remediable, right? There's nothing we can do about that. But many that arise are as a result of social systems that we have some control over. So for me, that's a really important kind of moral driver here, is that it's not just bad luck that results in that distinction. So yes to that. Now, really interesting question about the balance between social responsibility and personal responsibility. That's really complicated, in part, I think, because our attitudes to how we live our lives are as a result of the environment we're growing up in. So one thing that's really interesting in relation is stereotypes regarding their race. And you look at research in relation to like stereotype threat, for example. So this is where there's a negative stereotype about a group you belong to, and it actually impacts your performance. So for example, they do studies where they get students to do a math test, that's your baseline test. Then they get some students to answer a demographic questionnaire at the beginning where they have to tick a box saying they're female. That's enough to prime female students' minds to the stereotype that they're not as good at maths and they underperform. Do the same test, but no, amazing. Yeah. Really interesting, about how powerful these kind of internal views about ourselves are. Similar, you do the same thing again, but you ask students to tick a box about their background. Asian students who are primed about the stereotype that Asians are better at maths perform better, and this happens across, in so many studies that sort of demonstrate stereotype threat. So for me, there's just not a really clear distinction between kind of personal responsibility, how we perform, how much we exercise. We can't distinguish that really clearly from the social environment we live in. So for example, there's lots of research that weight stigma experienced by overweight and obese patients in the health system is an independent cause of weight gain and ill health. So I just think, we grow up in social systems. We learn expectations around how to behave, how much autonomy we have, how entitled we are, how much control we have over our lives from those social systems. So yes, I think personal responsibility plays a part, but I think it's quite hard to disentangle that from social responsibility. And I think often the narratives far too heavily focus on personal responsibility. So again, research with medical students suggests most think that overweight patients are primarily overweight because they're lazy and undisciplined. Whereas in fact, research suggests that 70% of that weight is as a result of genetic predisposition and environmental factors. So
thanks very much. Questions from the floor here? Maybe I'll chime in with another query I was thinking of as you were speaking. Actually, I've been discussing some of these issues with one of the authors of Zeke's paper, with Govind Prasad, in the context of monkeypox. And actually, Govind is now pushing, I know it wasn't in the original paper, but I think in some subsequent work, he's trying to push an account of justice, similar to what you just said, the idea of a causal link between a background disadvantage and their present, distress, right? And that causal link itself, something you want to sever as a matter of justice. And he said that's more appealing than a background prioritarian approach, where, it's not necessarily linked because you want to have, you want to prioritize based on that link. But I've kind of argued against this with him based on a couple of things, and I wondered what you thought about this. But the most important thing to my mind is establishing that causal link is actually really, really difficult and highly speculative, and there's a big risk we get it wrong. Both positively and negatively, right? We identify things that are causal links that they're not, and we fail to identify a lot of other causal links. And epistemic injustice then perpetuates into allocation injustice because we just get the causal links wrong. Whereas a general prioritarian approach, you just take a general, I think was it the ADI? There's general background things. You weight that. That's more straightforward because you don't have to worry about getting the causal link wrong. You just know you're pretty certain about general background disadvantage, and that weighting is going to be more straightforward. And then other reasons as well relating to prioritarianism being just more generally attractive than this kind of causal link thing, which is difficult to explain. But yeah, just wondered what you thought.
I sort of see your point with the causal link. So I think there's overwhelming evidence that our health system is biased, right? It's biased on the grounds of weight, certainly on the grounds of race, to a maybe lesser degree on the grounds of gender, but that varies a little bit by culture. So I think, that narrative is clear. Exactly how that works and how much it accounts for individuals' ill health, I think, is difficult to describe, right? And also because those are, that bias is a cultural norm, that changes over time. Right. So, the degree of bias on the grounds of race or, even gender orientation is quite different for an older population, certainly in New Zealand, than it is for a younger population. So pinning that down in terms of a causal story is quite difficult. But despite that, I think it still has really strong normative force. Like, it really matters to me that the inequality, that unequal outcome is as a result of injustice as opposed to bad luck. So, with that in mind, I think that, the thing about the ADI, so the Area Deprivation Index, is sort of quite interesting. There was some discussion in the US about whether, if what you're trying to do is address racial bias, why not just have, a measure that accounts for race, right? So ADI is promising because it quite closely correlates to race and it's a good proxy. But in the US, that just, politically didn't fly. in terms of saying, well, we're going to actively try and redress these racial disparities by giving, extra weighting to Black patients. You've got, issues around how you define that in terms of self-identified race, how that's categorized. And there's legislation and law against discrimination that might breach. So you've got, how you actually implement the normative value is complex in different contexts. Yeah.
Thanks very much.
Yeah.
Okay, we have a question from Mikey Dunn in the chat. Let's read it out. Another question, if I may. None of the main components of the argument look to obviously limit themselves to a pandemic-related health circumstance when we consider the basic reality of limited resource availability in publicly funded health systems. Yet in established resource allocation frameworks, there's a tendency to incorporate thin or non-discrimination type approaches, but not one focused on proactive corrections, for background inequities. Do we need to go further in all resource allocation decisions?
Sorry, I was reading a later comment while you read the first part of the question, so I'm just going to reread it. Yeah, sorry. Yeah, none of the main components I can look to, obviously. Right, yes. So yes, a lot of this is not limited necessarily to crisis standards of care and could be applied to questions around health allocation more generally. I think what's really interesting, though, is sort of Don Wilkinson's point and an assumption that we see in other literature that in a crisis, concerns about justice become less important because we just have to save lives. And I was trying to think, is there any kind of example where I would think, okay, let the equity thing go and just focus on saving lives? And for me, the line there is really only if you're looking at kind of social collapse. So you've got, such a significant proportion of the population dying that actually the whole system's starting to break apart. And I suppose that kind of reflects the idea in, rules as difference principle, that inequities are acceptable only to the extent that if you remove that inequity, you would make the worse off even more worse off. But for me, my version of when that might be acceptable to ignore equity is really a lot further along a continuum than what we saw in most of the literature coming out in 2020. So I suppose that's, interesting for me, that assumption that justice can be set aside or equity can be set aside in a crisis situation. Yes, I agree. It's frustrating to see thin accounts of non-discrimination compared to a more significant focus on equity. I think in New Zealand, we've really shifted on that in the last couple of years. There's really strong acknowledgement of systemic bias in systems and real efforts, not perfect, but real efforts to try and address that. Now, sorry, can I just comment, because Morali's made a good point actually in relation to Owen's question around the causal link, and I did mean to mention that. So Morali said actually, yes, there's social science literature, but they're suffering a real crisis in replication. Yeah, I agree with that. So the study around the maths, issue and, whether that impacts performance, there have been challenges in relation to that, into replicating that. And that's worth acknowledging. My view is, having looked at a lot of the literature on bias in systems, is that yes, there is a replication crisis, well, for some specific studies, but that doesn't undermine the overwhelming evidence of stereotype threat in the first place. So because these biases are kind of culturally constrained, you're not necessarily going to get the same outcome in each study. And I agree that, with your point about replication, but I think that those question marks aren't enough for me to sort of doubt the fundamental story, which is around the impact of bias, a lot of which is unconscious in our social systems. But thanks for bringing that point up.
Sorry, I just wanted to pick up on a point you just made in response to Mikey's question. So in relation to, in crises, in moments of crises, and particularly public health emergencies, whether there are, circumstances when you could be prioritizing utility and saving lives, maximizing lives saved over equity. I mean, and, of course, and it's easy to sort of reflect back on this pandemic and go, well, we didn't lose social cohesion and the whole thing didn't fall apart in the end. But the thing is, I mean, there was a lot of uncertainty and that you don't know that it's not going to. And I'm sure if you go down and talk to, the physicians who are on the ground in New York when it was coming through there, I don't think that they would, they knew that, this was all going to sort of pan out. And I think that that's kind of one of the characterizing features of these kind of emergencies. It's just the enormous amount of uncertainty, and you can only do what you kind of know what you've got to do with, right?
Yeah.
So, how, is there still sort of room for that?
Yeah.
Yeah.
And I think, that really does. I mean, there's a really interesting historical timeline from that paper that came out in early 2020. And I've spoken to, some of the authors about that as well. And, what their view on that real focus on maximising lives would be now. And, certainly I don't mean this to be a, critique of that, because I think if you look at some of the work that we did as well, like what we were doing under pressure in terms of people need advice, they need it now, isn't necessarily exactly spot on in terms of what we would say about that same issue 2 years from now. And so I think the debate has shifted, right, from that immediate crisis point. And, even in New Zealand, like real fear that our systems were going to be overwhelmed in the way they were in Italy or New York, to sort of a more balanced approach. So, on the ground, clinicians need to do what they need to do, and I'm certainly not trying to point the finger. What I think does matter is thinking about equity in our pre-planning, right? So that's that is there. Not being wedged to the kind of normative position that saving the most lives is the only ethical value. I think there's lots of pragmatic things that you can be understanding for. I just think holding that normative position is problematic. And then as things settle down, trying to consult with groups who are disadvantaged and excluded as much as possible, and just, really bring that equity focus in as and where it is practical. Yeah.
Maybe I'll check in on one of the things that you said towards the end. It was an interesting example concerning maybe for some ICU doesn't benefit them.
Yeah.
Right. And but then you didn't want to. You were against using that in sort of allocation, because that's really I don't know what the word is. It's not paternalistic, but it's something very problematic about then using that as a basis for denying ICU.
No,
right?
Sorry if that was unclear. That's a great point. No, I think that is a legitimate ground for denying someone ICU. And I think, so there's questions of clinical futility, right? And I don't think clinicians have an obligation to provide care that's futile. And clinicians have a duty of care to act in the patient's best interest. So if they genuinely think that ICU is going to prolong death and involve suffering and burden that isn't commensurate with the expected benefit, then that should be their advice. What I'm saying is it's very hard for patients who are the victims of injustice to hear that narrative and buy into that narrative. So I think that puts clinicians in a really difficult position, right? Because they don't want an equity-inspired tool. And I mean, again, this depends on the numbers a little bit in terms of whether this is a real problem or an imagined problem, but they don't want a tool that sort of forces them to be offering care that they don't think is beneficial. But at the same time, if you've got a group that doesn't trust clinicians to be acting in their best interests, that's really hard to implement, I suppose, is the point I was trying to make.
Yeah, I mean, I guess because the way I was thinking about that issue is one of the standards you use is, what would you do if there were no shortage of ICUs, or would you admit them or not, right? If the answer is you would not admit them in normal circumstances, right, then you wouldn't admit them in this triage circumstance either, because it's not in their interest, and you wouldn't do it either way. I guess my question was the objection that was made. Is this actually also an objection in regular terms when people are denied ICU admission because it's not in their interests? Or is it something about if they're denied in the context of COVID-19, they'll become something more troubling, and they're not bothered about it during normal times? So reaction is surprising.
I think it's both. So I mean, I think certainly there's critique that ICU and SOFA scores and things, have bias in them and can perpetuate disadvantage, that they are that overestimate the risk to Black patients in a way that doesn't kind of reflect the data or isn't fair. So yeah, certainly that critique exists in normal times. I think so one thing that happened with the crisis standards of care context is that it became a public discourse, right, in a way that it hadn't been previously. So suddenly it's all over the New York Times headlines. Doctors are biased in terms of how they allocate ventilators and how they allocate ICU. In combination with sort of the Black Lives Matter movement and a lot of evidence around systemic racism, suddenly you've got people questioning that in a way that I think it wasn't kind of on the public radar in the same way. Okay. Yeah.
Thanks very much. Julian has another question. Julian, want to unmute?
Yeah, so I mean, since you're attracted to egalitarianism, I'm wondering what you think about this version of egalitarianism. So I'm sure you're familiar with this paper by John Torek called Should the Numbers Count? And he says, imagine that, there's been a boating accident and there's a lifeboat with 5 people 10 miles north and a lifeboat with 1 person 10 miles south, and you can only go in one direction and the boats are sinking. He says what you should do is toss a coin, because that gives everyone a 50% chance of surviving. That's treating everyone equally. And John Harris has a version of this theory where he says what each of us wants is the longest, best quality of life for ourselves, the best chance of the longest, best quality of life for ourselves. So although Zeke has sort of poo-pooed a first come, first served approach or a sort of lottery, why aren't you attracted to, a lottery for allocating these resources that would just give, everyone their own best chance of the longest, best quality of life? I mean, especially given the problems you've outlined in attributing personal responsibility, some of those problems must also apply to trying to attribute social responsibility. So why not just adopt a lottery?
So I think I'd come back to the idea that public health has twin goals of public benefit and justice or equity. So while I've been focused on the importance of equity as something to take into account and balance with public benefit, and I'm certainly, I'm wanting to challenge the dominant narrative that came out in early 2020 that, the most important, clear, value was just public benefit. So I've been pushing back against that. But I do think public benefit counts, right? And I think that's the challenge for public health, is trying to achieve public benefit, good use of resources, and equity as well. I do think, would I accept a lottery? I think sometimes we can overestimate the certainty of our the value of our prognostic tools. So SOFA, for example, there's quite a bit of debate early on around, like, given how little we knew about COVID, how accurate was SOFA in actually predicting that? And so I think when you're sort of looking at utility and public benefit, you've got to look, at how confident we are in the data. And I certainly think, there are situations where if there's a lot of uncertainty, and you've got these kind of systemic inequities, that maybe a lottery is a valid way of going. The issue with the lottery, again, is just from a pragmatic perspective, how do you actually do that, right? So you've got a whole bunch of patients in a hospital, and you're tossing a coin as to who gets into ICU. I mean, part of the trouble there is addressing inequities in terms of access to healthcare, right? So what patients are actually making it into hospital, and so forth. I feel like there's something else I was going to say in relation to that as well. No, it's gone. So I guess that's what I would say from a public health perspective. Public benefit and equity are dual considerations and need to be balanced. And I think how you balance those in relation to different resources and different points in the crisis will be up for debate.
Just on this idea of first come, first serve, I have seen a defense of it, with not lottery, but first come, first serve on pragmatic grounds. And I'm wondering what you think about this. It's maybe it's not a defense, or maybe it's just an apology for it. But basically, this ideal, someone had written this ideal about ICU triage based on these criteria. When it actually came to reality, it was not implementable because of sequential presentation, right? So the idea being people do not all present at once. You don't usually have 10 people all at once saying, okay, who do we pick? We get five beds and 10 people and we pick. No, they come at different times of the day, right? And so when you deny ICU admission, you're basically speculating. You'll have certain people later in the day, but you might not. There's high variability. Maybe this is the only person that arrives today. Maybe case numbers have just dropped, or maybe it spikes up to 20, right? And this person wouldn't get the match if you were comparing against those 20. And so the idea is that if you say we deny you ICU now, even though it's going to benefit you, you're not giving it to somebody else. You're giving it to a hypothetical person that comes later, and that was basically not operationalizable, unless, of course, you're willing to put them in ICU and then withdraw them later, which is a possibility. But there's a lot of reluctance in the medical community to withdraw care later. So it put them in this dilemma, and then first come, first serve ended up in some cases, when there wasn't simultaneous presentation anyway, being a more pragmatic approach.
Yeah, and so I mean, I suppose some of the takeaways there is I think there was discussion about having time trials of ICU as a way of more fairly allocating those resources, right? So rather than just putting someone in an ICU and seeing how long they need, having kind of clear evaluation points and review points and removing someone if need be. What you've said actually, sort of the pragmatics about that reminded me what I was going to say in relation to Julian's point and the lifeboats. I suppose part of the challenge I have is, a lot of that philosophical literature, which just imagines people out of context floating around in lifeboats as though they're all the same person. And that sort of level of abstraction, I guess I just don't find it sort of as helpful as looking at actual cultures and actual countries and the social and power dynamics that go on in there, because you're right that there's never sort of 20 patients that turn up and you can toss a coin amongst all of them, and that's not how it works in reality. And in reality, you're sort of, in relation to a government allocating resources, you're existing in a really deep historical context. You're not just choosing between 5 versus 1 totally equivalent people on a lifeboat. Julian's coming back.
Follow up, Julian?
Well, that's not actually strictly true. So just to take one of the examples that you raised, which was the distribution of vaccines in tiered age groups, starting with the oldest, 90 to 100-year-old, 80 to 90, and so on. That was a utilitarian distribution aimed to save the greatest number of lives. You could have adopted a more egalitarian like tossing a coin of just randomly allocating in people over the age of 60. You would have saved fewer lives, but you would have given more people a chance of accessing the vaccine earlier. So, we were simply faced with this choice of, do we give greater weight to equality or do we give greater weight to utility? Now, that's exactly like the lifeboat case. And we made the choice for utility. So I don't think it's just that these are purely fantastic, kind of thought experiments. This is a case that if you take seriously everyone's claim to having the best chance of the best life for themselves, you would have distributed those vaccines in a different way. So I don't think it's true that these are just sort of fantasies of philosophers.
Yeah, sorry, no, I didn't mean they were just fantasies of philosophers. I'm just saying I don't think they necessarily get you as far as we need to go in terms of thinking about how we allocate resources. And I would agree with you that the age prioritization based on science, the science and the risk, age was clearly the largest risk factor in relation to severe COVID and death. So that was absolutely a utilitarian approach. And a lot of public health is informed by that, and I think that's legitimate. But I think the fact that, for example, the New Zealand government wouldn't follow that same line and also offer the vaccines to different groups in the context of the historical reality where we know they're disadvantaged as a result of sort of systemic racism, that's the bit that's problematic, right? Because you're running this sort of utilitarian line, but then you're not prepared to sort of follow it through in a consistent way for these groups. And that perpetuates that disadvantage. And, the historical, the kind of cultural reality there is that the median age for white people, European people in New Zealand is 37. The median age for Māori is 25, and for Pacifica people is 23. So, you've got all sorts of differences between those groups and in terms of what that means for when they'll access those vaccines.
Just a note on this Tarekian debate. I thought you actually one of the slides you had, the really useful, the cartoon slide with the equality versus equity is one of the better responses to the Tarekian challenge. Because one thing, and this is something I've written about with Zeke and COVID and others, is that even though there are these trade-offs, one of the nice things, one of the interesting things and important things is there's a lot of overlap. And if we're looking at equity and not equality, and you looked at the picture, right, with the people in the 3 boxes, and then you stack them, right? The equity version also aligns with utility, right? So you both get more equitable distribution based on need. The person that needs it most gets the extra support, and you also maximize utility at the same time. And so the response to the lottery, one response to the Tarekian lottery person is that, well, this isn't what matters. Equality is actually not what we're seeking. Equity is what we're seeking. And in public health, I think equity, people do use both terms, but I mean, equity is, I think, the stronger concept.
Yeah, equity, I absolutely agree. And I think if you look at the literature coming out from the WHO, for example, that's the really strong narrative there is around equity. And I would agree, that in many cases, equity will align with utility. I think it's the more interesting parts are when they come apart, and then is there any justification for prioritizing equity at the expense of utility? But you're right, often they will align. And, the vaccine distribution was an example of that. Yeah.
So thanks everyone for attending this CBME seminar. Thanks for your attention and for your questions. I hope it was an interesting account. My hope is also that it won't be practically relevant in Singapore anytime soon, insofar as, Singapore never needed to actually activate. There were ICU triage guidelines in Singapore. We didn't have time to discuss that, I guess. I was wondering if anyone's going to raise it, but it was never activated. Singapore never got to that. And I guess one would hope this stays theoretical, but it is important that we continue to have these discussions so that if there another, public health crisis comes about, and this does need to become activated, that we're confident of content of such triage guidelines. And also, of course, as you say, applying them to other areas, and Mikey kind of suggesting a much broader approach to integrating equity into other resource allocation decisions makes this an ongoing and important topic. So thanks very much, Angela, for this talk.
Thanks for having me.
And I guess we'll close the session there.
Great. Thank you.